Hey everybody, it's Dr. Becker. We're jumping into chapter 58. This is glucocorticoids, so steroids, right, in non-endocrine disorders. What we're talking about then is that how do we use steroids pharmacologically in people with a normal functioning adrenal glands, normal functioning hypothalamus, like the endocrine system is working just fine, but for some other reason, we're going to give people steroids. So in true Laney's fashion, one of the first things they do is review how steroids are working in our body normally under normal conditions, so that then we can understand when we give someone excess steroids dosing, what does that do? What are we expecting to happen in the body? And therefore, how do we educate our patients and how do we know when to give steroids and what we're hoping to accomplish, right? So Laney's always kind of starts with that basic review. And I think this is really important to understand because I know you've heard this before, but now from a prescriber lens and from the view of an APRN, understanding steroids at this kind of level or through this lens is really important because we use steroids a lot. In fact, in the beginning of your chapter, Laney's actually says that their ability of glucocorticoids to greatly improve quality of life borders on the miraculous. And that is not an exaggerated statement. The fact that we have steroids at our disposal is huge. Without them, treatment of a lot of conditions would be very difficult and people's quality of life, their morbidity and their mortality would be way higher. So we use steroids a lot, but they're a little tricky. They have nuances to them. So we have to understand this well. So to review, it's our adrenal cortex that produces corticosteroids. Corticosteroids include mineral corticoids, which are the modulators of salt and water balance, and then glucocorticoids, which influence our carbohydrate metabolism and these other processes of the body that we're going to go into detail about. So there's two types of corticosteroids, right? Mineral corticoids and glucocorticoids. For the most part of this chapter, we talk about the glucocorticoids. So our body makes our own natural glucocorticoid, which is cortisol. So I tend to use those words and terms interchangeably. The really neat thing about glucocorticoids that we give exogenously from the outside is that they are nearly identical to our body's own endogenous glucocorticoids. That's how good they are. So they're very effective and they work really well. So the first thing that Laney's goes through to review with you is how do our endogenous glucocorticoid, our endogenous steroids of our body, our own cortisol, how does that affect us physiologically? And then how does that how is that affecting our body when we give it exogenously from a pharmacologic perspective, right? So our physiologic effects of our own cortisol means that those are the lower doses that our body naturally produces, and those are what we need to maintain normal physiologic function. I think sometimes, I do anyway, people forget that cortisol is a important compound that plays a role in a lot of different processes within our body. And so that's really important to understand. So we're going to go through those. Remember when we're talking about the natural physiologic cortisol, this is lower doses, right? This is not, our body doesn't kick out an equivalent of 100 milligrams of prednisone a day. These are much lower doses at our normal rate for our body, but they affect so many physiologic processes, okay? So the first one that they talk about is the metabolic effects. So our cortisol is a huge player in how we metabolize our carbohydrates, our proteins, and our fat, hugely. So you have to have that as a component to properly give ourselves energy through the metabolism of our food. So here it kind of talks a little bit about these metabolic effects. So as it is needed for the synthesis of carbohydrates, it elevates our blood glucose. It promotes storage of glucose in the form of glycogen, which is really important, right? We have to be able to store our glucose to have as a reserve, and that process is needed, cortisol is needed for that process, is what I'm trying to say. But the other thing that it does is affects our fat metabolism, which is the stimulation of lipolysis, which is fat breakdown, right? And then also redistribution of fat. is what the cortisol will be working on in our body. It also can reduce muscle mass, decrease the matrix of the bone, cause thinning of the skin, and causes a negative nitrogen balance. And we'll talk a little bit more about that. But the metabolic effects are real. It's needed also for protein metabolism, and that's why it can reduce muscle mass if we give too many glucocorticoids. Okay, it also affects our cardiovascular system. It's a really important piece of how we regulate that. When we have our low levels of our own cortisol, our capillaries become more permeable, vasoconstriction is suppressed, and the blood pressure can fall. When we give or when we have cortisol circulating, it also can increase our red blood cells and decrease our lymphocytes, eosinophils, basophils, monocytes. So in other words, our body can use our cortisol to affect our blood pressure, and it uses our cortisol to affect our hematologic system of how much circulating red cells and white cells that we have. So that's really important, that if we mess up people's cortisol levels, we could be messing up their cardiovascular system and their hematologic system. Okay. Next one that the book talks about too, that is not on the slide that I want you to consider maybe adding down in here, is the central nervous system effects. Cortisol is part of that process because it plays a role in neural excitability. So when that is disrupted, low levels can cause bad depression and high levels can cause excitation and mania, which makes sense that we would give people large amounts of exogenous steroids and they get kind of ramped up and crazy. Like, that's where that comes from, is because naturally our body uses cortisol also within the CNS. The big one we talk about, especially in acute care, is the effects of the stress response. So at times of physiologic stress, so it's saying here, surgery, infection, trauma, hypovolemia, but also traumatic experiences mentally, right? We go into the fight or flight mode, and that is done through our body's release of cortisol and our body's release of epinephrine. So when you go into a stressful experience and your body kicks on that fight or flight, you are going to have naturally higher levels of cortisol and higher levels of epinephrine. And that results in maintaining your blood pressure and maintaining your glucose level, which are two critical things you're going to need to fight, right? To stay active and ramped up to meet this stress response. If you have insufficient release of your glucocorticoids, you get hypotension and hypoglycemia, which is bad, right? That's going to paralyze you and not allow you to stay in fight or flight. If you're under very severe stress and you don't have enough glucocorticoid, that's when you can get circulatory collapse and even death. So this is where we come, especially as acute care providers, to understand that when people are acutely ill, the natural endogenous circulating cortisol levels are something we have to think about because they play a role in so many physiological aspects under normal conditions. And they're really needed to have enough cortisol circulating in your body to meet your needs during a stress response. The next concept of how our cortisol works normally in the physiologic way in our body is that it can affect our water and our electrolytes because they do have some action within the kidneys. So they can exert actions like that of aldosterone, and they can act on the kidneys to promote retention of sodium and water while increasing urinary excretion of potassium. And that can result in hypernatremia. So too much steroids can drive up your sodium level, can drive down your potassium level, and can cause the edema. So you can see that in people that are on chronic large doses of steroids, that they can start having abnormal electrolytes and start having problems with edema. Most glucocorticoids used as drugs have a very low mineralocorticoid activity. So meaning that this is not something that we see as much in the typical glucocorticoids, but it can be, especially when we use them at big doses over long periods of time. So how does our body work on controlling naturally when we're in a normal state of health? How does our body control how much cortisol is released? Well, it's this beautiful negative feedback loop. So what happens is the CNS stimulus and stress, either or, works then and signals the hypothalamus that this is occurring. So it turns on this process, and the hypothalamus will release the corticotropin releasing hormone, which is CRH here. Okay. The CRH then stimulates our anterior pituitary and says, whoa, we need you to produce more of the ACTH, which is adrenocorticotropic hormone. That then signals the adrenal cortex, please make more glucocorticoid, cortisol, and release it out for physiologic use. Okay. Cortisol, which is the principal endogenous glucocorticoid that we have, cortisol has two basic effects from there. Okay. First, it's going to cause all those those physiologic things we just reviewed. Our metabolism, our cardiovascular system, the CNS system, all of that, the stress response, etc. So it works by stimulating a lot of things. But it also sends signals back to the hypothalamus and the anterior pituitary, telling them whether or not there's enough cortisol. So it regulates itself. And when it feels it's at the level needed, it'll signal these two to shut off, which is great. So once it's like, nope, I have enough circulating cortisol, it sends it back here in this negative feedback loop and says, my cortisol levels are high enough, decrease production of CRH and ACTH. So that's lovely. But the problem comes in when we give exogenous or outside large doses continuously or chronically of steroids, right? And so we shut this process off. Remember I said that the glucocorticoids we give are almost identical to this. So this body now says, whoa, we have way too much glucocorticoids, and continually keeps this suppressed. So when you are on larger high doses of steroids chronically over time, you are shutting down your own feedback loop and telling your hypothalamus and your anterior pituitary to shut down their release of the CRH and the ACTH, which then tells the adrenal cortex, quit making our own endogenous glucocorticoid. Okay. So now let's move into what happens when we give exogenous glucocorticoids, when we prescribe people steroids. Okay. Glucocorticoids differ from most drugs in two ways. One, the glucocorticoid receptors are located inside the cell rather than on the cell surface, which is very different. And two, glucocorticoids modulate the production of regulatory proteins rather than the activity of signaling pathways. So what does that mean? So let's review that. Glucocorticoids penetrate the cell membrane and then bind with receptors in the cytoplasm and convert the receptor form to the active form. Then the receptor steroid complex will migrate to the cell nucleus, where it binds to chromatin and DNA and alters the activity of the target genes. In most cases, this means that the target gene is increased, which then causes increased transcription of messenger RNA that code for specific regulatory proteins. Some cases and sometimes, though, the activity of the target gene is suppressed and the synthesis of certain regulatory protein declines. So I do want us to understand this better. So I'm going to play the clip from Osmosis. Maybe you've already listened to it or not, just this first part to kind of reinforce what I've spoken about thus far.
Glucocorticoids are a group of steroid hormones, which are secreted by the two adrenal glands that sit like hats, one on top of each kidney. Each one has an inner layer called the medulla and an outer layer called the cortex. The adrenal cortex secretes different corticosteroid hormones, like glucocorticoids, under the control of adrenocorticotropic hormone, or ACTH. Normally, the hypothalamus, located at the base of the brain, tropic hormone, known as ACTH. ACTH then travels to the pair of adrenal glands and binds to the ACTH receptors on adrenocortical cells. This causes the adrenocortical cells to release the glucocorticoids from the zona fasciculata, which have powerful anti-inflammatory and metabolic effects. These glucocorticoids have a negative feedback effect on the hypothalamo-pituitary adrenal axis. meaning excess corticosteroids suppress the release of both CRH and ACTH into the circulation. Now, once made, glucocorticoids enter the circulation and travel via the blood to reach the target cells. Steroids are lipophilic molecules, so they cross the cell membrane, enter inside the cell, and bind with a cytoplasmic receptor protein called a glucocorticoid receptor. Now, this glucocorticoid receptor complex undergoes some structural changes, which allows them to enter inside the nucleus and bind with the glucocorticoid response elements, or GRE, on the chromatin. Now, this induces transcription of specific mRNA that's used to synthesize different proteins, which in turn modifies various cell functions and metabolic effects in the body. The most important glucocorticoid in humans is cortisol, and it's generally released during times of stress, like during an illness or starvation. Cortisol helps to regulate both the immune response as well as cellular metabolism, like gluconeogenesis. With regard to the immune response, cortisol promotes an overall anti-inflammatory state by inhibiting the two main products of inflammation, prostaglandins and leukotrienes, as well as inhibiting interleukin-2 production by white blood cells. Now, for cellular metabolism, cortisol promotes overall catabolic effects on the body. In peripheral adipose tissue, cortisol triggers lipolysis, which is the breakdown of fats into free fatty acids. In the muscles, cortisol stimulates proteolysis, which is the breakdown of proteins into amino acids. Often these free fatty acids and amino acids serve as a substrate for gluconeogenesis, a process where the liver cells produce new glucose molecules from non-carbohydrate sources like amino acids and free fatty acids. High cortisol levels also increase insulin resistance in tissues, which means that insulin becomes less effective at moving glucose into cells, leading to an increase in blood glucose levels. The increased glucose level also stimulates the release of more insulin, and because this is similar to what happens in people with diabetes, this effect of cortisol is called diabetogenic. The end result is that we have a lot more glucose in the blood, which can be used as fuel during times of stress. Finally, cortisol also plays a role in maintaining blood pressure levels, since it upregulates alpha-1 adrenergic receptors in blood vessels, which causes vasoconstriction. Now, let's switch gears and focus on synthetic glucocorticoids. Synthetic glucocorticoids in our body produce the same effect as endogenous cortisol, but they also increase the number of neutrophils in the blood. Let's put it this way. Glucocorticoids decrease the production of a protein that enables neutrophils to attach to the endothelial lining of the blood vessel. As a result, neutrophils detach from the endothelial lining and enter the circulation. This process is known as demargination. At the same time, these medications also decrease lymphocyte, monocyte, basophil, and eosinophil counts. Now, based on the duration of action, synthetic glucocorticoids can be classified into three groups. The first group includes short-acting glucocorticoids, with duration of action of 8 to 12 hours. Cortisone and hydrocortisone fall under this group. Cortisone is taken orally, and in the liver it requires conversion to hydrocortisone. Therefore, it is not active when used in topical forms. On the other hand, hydrocortisone is chemically identical to cortisol and can be taken orally, intravenously, or intramuscularly. It then enters the circulation, goes to the target cells, and very rapidly takes effect, but only for a short duration of time. That's why hydrocortisone is the drug of choice in acute adrenal insufficiency. Hydrocortisone is also available in topical forms. The second group are intermediate-acting glucocorticoids, with duration of action of 12 to 36 hours. Prednisone, prednisolone, methylprednisolone, and triamcinolone fall under this group. Prednisone is taken orally, while prednisolone has peroral, intravenous, and topical use. Next, methylprednisolone can be taken orally, intravenously, intramuscularly, or intraarticularly, while triamcinolone has oral, intramuscular, topical, and intraarticular use. In comparison to short-acting glucocorticoids, intermediate-acting glucocorticoids are almost 4 to 5 times more potent, meaning a lesser dose is needed to produce the desired response. Finally, the third group includes long-acting glucocorticoids with a duration of action of 36 to 72 hours. Betamethasone and dexamethasone fall under this group, and they can be taken orally, injected into a vein, muscle, or joint. In addition, dexamethasone can be used topically. Finally, these medications are 25 times more potent than short-acting glucocorticoids. Now, the clinical use of glucocorticoids can be subdivided into several groups. First, glucocorticoids are used in the treatment of adrenal conditions, which are characterized by low corticosteroid levels in the body, such as primary adrenal insufficiency, also known as Addison disease. With Addison disease, the underlying problem is due to damage of the adrenal glands themselves. Another condition is congenital adrenal hyperplasia, which is characterized by genetic defects that prevent the synthesis of specific enzymes that make cortisol. Now, to treat these conditions, we use short-acting glucocorticoids, which are, in this case, also referred to as physiologic replacement therapy. Physiologic replacement therapy should mimic the normal physiologic diurnal pattern, meaning that in the morning, individuals should receive the largest dose, and later in the afternoon, a smaller dose. In addition, a life-threatening adrenal crisis, which is also known as Addisonian crisis or acute adrenal insufficiency, is treated with hydrocortisone due to its rapid effect. Next, glucocorticoids are used as an anti-inflammatory immunosuppressive therapy in individuals with asthma, conditions with autoimmune and inflammatory components, such as rheumatoid arthritis, Crohn's disease, ulcerative colitis, acute multiple sclerosis exacerbation, and idiopathic thrombocytopenic purpura, and in inflammatory conditions of the skin, eye, ear, or nose, like eczema, allergic conjunctivitis, or rhinitis. Also, these medications are used to treat hypersensitivity states, such as severe allergic reactions, and prevent graft versus host disease. Next, we have miscellaneous conditions which include chemotherapy-induced vomiting, hypercalcemia, and mountain sickness. Furthermore, betamethasone can be given to pregnant women before birth to speed up fetal lung maturation. Finally, glucocorticoids are used in neoplastic conditions such as adjuvant therapy due to their anti-lymphocytic effect, which is characterized by a decreased clonal expansion of T and B lymphocytes. This makes them effective in the treatment of hematopoietic cancers, such as acute lymphocytic leukemia, Hodgkin lymphoma, and non-Hodgkin lymphomas. Finally, it's important to note that dexamethasone is commonly used to relieve cerebral edema in individuals with metastatic or primary brain tumors. Moreover, dexamethasone is a very potent medication and often causes marked suppression of the hypothalamic pituitary adrenal axis, even if given in a low dose, meaning dexamethasone provides a negative feedback to the pituitary gland, which leads to suppression of ACTH secretion. This, in turn, lowers the natural production of cortisol. Due to this, it's used in the overnight dexamethasone suppression test, where it's used to diagnose the presence of Cushing syndrome. Cushing syndrome is an endocrine disorder caused by too much cortisol production. It could be caused by Cushing disease, where a pituitary adenoma overproduces ACTH. Symptoms include obesity, where the extra adipose tissue tends to build up between the shoulders, leading to a buffalo hump, in the trunk, causing truncal obesity, and in the face, causing moon facies. Hyperglycemia and diabetes often result from the increased gluconeogenesis and insulin resistance. Muscle weakness and skin stretch marks can occur due to protein breakdown. Hypertension, osteoporosis, and increased risk of bacterial and fungal infections are also common problems caused by excessive cortisol. Now, when a person is suspected to have Cushing syndrome, they are given a low dose of dexamethasone, which suppresses ACTH production in the pituitary gland. Normally, that should cause a decrease in serum cortisol levels. But if Cushing syndrome is caused by endogenous cortisol production, then the cortisol level should remain unchanged. High cortisol levels determine the test as positive, and it proves the presence of Cushing syndrome. Side effects of all the synthetic glucocorticoids are rare when administered for physiologic replacement therapy, but the risk increases in individuals who are receiving high doses for a prolonged period of time. These side effects are pretty similar to Cushing syndrome, since they act just like the cortisol produced by the adrenal glands. When we get these symptoms from an outside source, it's called iatrogenic Cushing syndrome. This is actually more common than regular Cushing syndrome, since glucocorticoids are frequently used to treat fairly common conditions, like rheumatoid arthritis and asthma. Other side effects include fluid and electrolyte disturbance, such as fluid retention, hypertension, and hypokalemia. Endocrine side effects such as hyperglycemia, diabetes, and suppression of the hypothalamic pituitary adrenal axis, which can lead to adrenocortical atrophy. Next, since they cause immunosuppression, they are associated with an increased risk of infection and impaired wound healing. In addition, glucocorticoids can cause musculoskeletal side effects, which include myopathy and avascular necrosis of femoral and humeral heads, but also osteoporosis and pathological fractures because they decrease osteoblast activity and increase osteoclast activity. Finally, individuals treated with glucocorticoids can complain about psychiatric disturbances, such as depression, insomnia, psychosis, and mood swings. But they can also develop peptic ulcers and cataracts. Also, glucocorticoids cause inhibition of growth in children. Now, it's important to note that individuals that are treated with long-term glucocorticoid therapy should receive additional stress doses to prevent adrenal crisis. Stress doses are commonly used before or after surgery, or during severe illness. Moreover, individuals taking long-term glucocorticoid therapy can take a double daily dose every other day to prevent the suppression of hypothalamic pituitary adrenal axis and eventual adrenocortical atrophy. This way of taking glucocorticoid therapy is also known as alternate day therapy, or short ADT. Now, we've made a mnemonic to help you retain some of the hard-to-remember facts related to the synthetic glucocorticoids. To start, let's think of a crazy 3-story apartment where each level only has one room, and the room size decreases as we go towards the top. So the long-duration glucocorticoids get the room at the bottom, the intermediate in the middle, and the short duration at the top. Okay, since most of our glucocorticoids contain SON in their names, we'll have sons representing these medications. So on the top floor, we'll have hydrocortisone, which will be represented by a boy in a pool playing water polo. For indications, let's have him play water polo against Thomas Edison, who's holding a light bulb. Now, mixing electricity and water is dangerous, which helps you remember that hydrocortisone is used to treat the life-threatening Addisonian crisis. He also has a bunch of rashes all over to represent this medication's topical uses. Okay, on the next floor down, we have the intermediate duration glucocorticoids. So here we have 3 medications with the pred in them. So let's dress up 3 boys in predatory shark costumes to represent prednisone, prednisolone, and methylprednisolone. Now their room is on fire, so one of them is putting it out with a fire extinguisher to represent their anti-inflammatory properties. Another one is eating one of the misbehaving white blood cells that set the fire to help you remember that they can be used for autoimmune diseases. Finally, methylprednisolone is connected to an IV line, or holding tablet, to help you remember it can be used in respiratory emergencies like asthma exacerbations. Okay, let's go to the last room, which represents the long-duration glucocorticoids. So here we have a boy named Dexter who's doing math, for dexamethasone. Helping him is another boy with a beta fish on his shirt, and he represents beta-methasone. They are calculating the force needed to crush different materials for his experimental trash compactor, which represents that it's used to diagnose Cushing syndrome. The misbehaving white blood cells also spread to this floor and are setting fire to the room, so they can also be used to treat the same conditions as the intermediate duration glucocorticoids. Finally, the boy in the beta shirt is carrying a baby, so you know that it's the preferred medication for pregnancy. Now let's head out of the building for the side effects. We have a trash compactor outside for iatrogenic Cushing syndrome, which is caused by glucocorticoids not produced inside the body. So to help you remember some of the symptoms, let's put some stuff in this trash compactor. There's a buffalo with a fat torso, wearing a smiling moon mask to help represent buffalo hump, truncal obesity, and moon facies. We can put a blood pressure cuff wrapped around a bone with holes in it for hypertension and osteoporosis. There's an obese man carrying a candy bar to represent hyperglycemia and diabetes. There's bacteria climbing around him to represent an increased risk for infections. Finally, there's a very sad man representing psychiatric problems like depression. He's sad because he's in the trash compactor, but also because his eyes are cloudy white, representing cataracts, and his stomach is leaking acid to remind you of peptic ulcers. Alright, as a quick recap. Based on the duration of action, synthetic glucocorticoids are subdivided into 3 groups. Short-acting glucocorticoids, 8 to 12 hours, which include cortisone and hydrocortisone. Intermediate-acting glucocorticoids, 12 to 36 hours, which include prednisone, prednisolone, methylprednisolone, and triamcinolone. and long-acting glucocorticoids, 36 to 72 hours, such as betamethasone and dexamethasone. Glucocorticoids can be used as the physiologic replacement therapy in adrenal disorders like primary adrenal insufficiency or congenital adrenal hyperplasia. However, they are more commonly used as anti-inflammatory agents and immunosuppressants. Finally, the side effects are rare when administered for physiologic replacement therapy, but the risk increases in individuals who are receiving high doses for a prolonged period of time. The most important side effect is iatrogenic Cushing syndrome. But wait, there's more. Here's a mind map with all the mnemonics. Go ahead and pause the video so you can test yourself and see what you remember. Stay tuned for the answers after the credits.
All right, so I hope that's helpful and don't have to listen to me drone on as much. I think that was an excellent review of everything that I'm trying to say and a good way to hear it and to remember those different types of short-acting, intermittent acting, and long-acting, and their mind map of how to try to help you remember what's associated with each of them. The next part that we go into in the book is to just talk about some of the different diseases, but this is here a slide from the book that also has some good points for us, okay? Glucocorticoid dosing is highly individualized. It's really discovered through trial and error. You start low and go slow. Long-term use, we want to be on the smallest effective amount possible. Prolonged treatment with high doses is used only if the disorder is life-threatening or permanent disability, right? Because we know it's really dangerous to turn off the HPA axis. Gradual weaning is going to be necessary. Alternate day therapy is a big thing that could really be helpful for people to prevent their adrenal atrophy. And then we do try to, if people are on it all the time, they should take it before 9 a.m. to kind of help mimic their diurnal normal processes of our cortisol in our body. Okay. Let's review how we use these in certain indications of diseases. So the first one is rheumatoid arthritis. It is indicated for adjunctive treatment for acute exacerbations because they reduce inflammation and pain. It's important to remember, though, if you give people steroids, it's not actually the treatment for the disease. It's just a symptom treatment. You can also use steroids in joint injections. It's used in lupus, systemic lupus erythematosus, which is SLE. Very similar in a lot of ways to rheumatoid arthritis, but it's just not limited to joints. And that has the potential to be fatal if you were to get significant like pericarditis or nephritis. So most of those exacerbations of lupus can be managed with high aggressive doses of steroids. There's a role for steroid use in inflammatory bowel, which the video talked about, ulcerative colitis and Crohn's disease. We can also use them in gout and inflammatory disorders of the eyes. Other things like tendinitis and that thing can respond very well to steroids. Steroids have a role in allergies, like allergic rhinitis, bee stings, drug-induced allergies. But because there is somewhat of a delay in their onset, they have very little value as sole therapy for severe allergic reactions like anaphylaxis. You also have to give epinephrine. Asthma is a great steroids for asthma can have great effect for that, but they're not always mainstays of treatment because we don't want to shut down the HPA axis. Steroids are the mainstay of dermatologic disorders, let me tell you. I hate dermatology. It is not my niche. You're going to either love it or hate it. But yes, it's very tough because as you're out there, people get the craziest skin things. And I always had a preceptor that I worked with and then worked with alongside of them that always said, just throw some steroids at it. It'll cure everything in the skin. So you'll see a lot of steroid use for skin. And then it is a mainstay of treatment for different types of respiratory distress. Big things that we also need to know is that it has those risks like we talked about, osteoporosis, adrenal insufficiency. It can upset your stomach and it can cause that kind of iatrogenic diabetes as well. Also, especially when you're in practice as an acute care APRN, whether you're CNS or a nurse practitioner, if you're dealing with direct patient care, people that are on chronic steroid therapy have a huge risk for infection because you are suppressing their natural host defenses, and so they're highly susceptible to infection. These are the people that get some of those funky zebra type conditions. And so you have to really be cautious of that and respectful of that. Even if they're only on maybe 10 milligrams of prednisone a day, which isn't the biggest dose ever, but they're still going to be at risk for immune issues. They would be immunocompromised because of chronic steroid use. That also extends into wound healing. The other things you have to think about, though, also are the high blood sugars, which we know, but also the myopathies and that fluid and electrolyte disturbances that can lead to abnormal electrolytes like low potassium and can lead to fluid and swelling shifts. Also, some people don't always connect that recurrent doses of steroids or prolonged doses of steroids lead to people having a really high increased risk for cataracts and glaucoma. Systemic glucocorticoids can cause that open angle glaucoma. So that's important to monitor for people. And then the issue of developing that adrenal suppression is what your book talked about. So please understand, especially as you move into your diagnosis and management courses, that adrenal suppression is the most dangerous effect of long-term steroid use because you have to monitor for it and treat it appropriately if it were to occur. When we give our exogenous steroid, we're inhibiting the synthesis and release of our endogenous cortisol by the adrenal glands. So during the long-term therapy, our pituitary loses much of its ability to even manufacture ACTH. And so there's a prolonged period where you don't have ACTH and the adrenal glands atrophy and they lose their ability to synthesize the cortisol. So if you try to get people off of steroids, they can't turn back on their adrenal gland. So when prolonged steroid therapy is stopped, there's a period during which the adrenal glands are unable at all to produce that. This can be life-threatening, and people have to really be treated with aggressive steroids again to be managed for that. The time for adrenal recovery is highly variable, and I have seen this in practice from within a week to over a year of not being able to resume their adrenal to be functioning enough to get by. So it is a very big deal, and people can die from adrenal insufficiency related to their chronic or high-dose use of steroids. So it is imperative to understand that if someone is on long-term steroid therapy and they are hospitalized for infection, hospitalized for surgery, or in a period of really high stress, you have to pay attention, and that's where we get the idea of stress-dosed steroids. So we have to at least meet the demands of their cortisol. So they often need higher doses than they're already taking. Okay, if someone has whatever autoimmune disease and they're taking 40 milligrams of prednisone every day, and now they come in for a hip replacement, something, that has to be managed because their body is used to having just that homeostasis, that larger amount of exogenous cortisol. And now we're putting them under an increased stress on the body, which is surgery is, general anesthetic, the disruption of the skin, all those things are happening. They have to have higher doses. So those are the people that get high dose methylprednisolone throughout their time. If you don't, that's when people crash and they get that hypotension, hypovolemia, hypoglycemia, and that's when they can get circulatory collapse and die. When we're talking also about the potential, like we always do when we give a drug, how it interacts with other drugs, you have to be very, very cautious with digoxin because the glucocorticoid can mess with potassium, right? And we know that that's a big deal, hypokalemia and digoxin. So if they're combined, you could be life-threatening low potassium. If you combine steroids with a thiazide or loop diuretic, you can also have significant hypokalemia, so we have to monitor for that as well. The other issue that people worry about is if you're giving the steroids with NSAIDs because of the risk for the GI upset or ulceration and bleeding. Obviously, people may need to have their insulin or diabetic medications adjusted accordingly when you add on steroids. The other interesting thing is vaccine response. So if people are on high-dose, long-acting steroids and they get a vaccine, those high levels of cortisol can decrease your antibody response to steroids. And if you ever give somebody a live vaccine, when they're on those high-dose steroids, the immunosuppressant action of the steroids can increase the risk for actually developing and spreading the viral disease. So that has to be managed appropriately as well. Couple things to remember also about when not to give steroids. Number one, steroids are contraindicated in patients with a systemic fungal infection and contraindicated then for people that want to receive a live virus vaccine. We have to use steroids cautiously in pediatric patients and women who are pregnant or breastfeeding. We also have to give judicious, cautious to people with other chronic morbidities and our elderly patients like heart disease, heart failure, peptic ulcer disease, already poorly controlled diabetes, or infections that are resistant to treatment, or if they're on those other medications we talked about. When somebody is going to be tapered off of their steroids, this is usually done by specialists, number one, because the specialist was ordering the steroids in the first place for their autoimmune disease or whatever it was, but you may be affecting or part of that process as well. So you typically do kind of the schedule as outlined in your book. I have seen this in practice and use this in practice as well. So you taper the dose to a physiologic range over 7 days. You switch from multiple daily doses to single doses. You taper the dose then to 50% of the physiologic values over a month, and you monitor for their endogenous cortisol levels and their basal levels. You do steroid testing. And as a rule, that's going to take weeks to months to do. Tapering is considered probably unnecessary when you've been using those steroids even in high doses for less than 3 weeks. That's typical, but there have been people that even by week 3 are beginning to suffer from some adrenal issues, and when you succeed their steroids, they can have some insufficiency type syndromes. Okay, I think your book does a really nice job of giving you the patient education for glucocorticoids, and so I think that's really great, something to be aware of and to be able to go back and look through. In your practice in the future, these are the things you should be thinking of. If you give a steroid to somebody, these are things we should be talking about. Sometimes, especially in an acute care or a walk-in clinic, urgent care, those kind of things, I feel like sometimes we dish out 5 days worth of prednisone like candy, and we're not always thinking about it. And typically, like I said, those small doses, even of 40 milligrams a day, are probably very safe. But it's still something that we should be looking at and treating pretty judiciously. All right, you've made it through steroids. As always, give me any, or reach out if you have any questions or concerns. Thank you.